Welcome to the second part of acute vomiting. In this part, we'll talk about some of the diseases in which the vomiting is a predominant symptom, or the diseases in which vomiting is a symptom as well. We move on to some of the common emergency conditions that might present with excessive vomiting and that are life-threatening or organ-threatening as well. So let's move on. First, we'll talk about acetaminophen toxicity. The patients present with anorexia, malaise, vomiting, and generalized abdominal tenderness as well. This is drug intake. The person has a history of drug intake, acetaminophen toxicity. So what we do in these patients, we hydrate, we check for the acetaminophen levels, and we refer the patient to the drug or toxicologist. Moving on to acute appendicitis. Let me spend some time over here. Acute appendicitis is the most common presentation in emergency department. It presents with epigastric pain or at times present with right iliac fossa pain. It is associated with nausea. It is associated with vomiting as well. So if a patient presents to you with periumbilical or epigastric pain that is radiating to right iliac fossa, think of an acute appendicitis. But at times, there is no preceding epigastric pain or periumbilical pain. And this shows the appendix is perforated or the later complications of appendix has already been begun. So the patient present with right iliac fossa pain, starting off with from epigastrium and periumbilical pain, moving on to right iliac fossa pain. There is increased rebound tenderness, and at times there would be rectal tenderness as well. To diagnose acute appendicitis is most of the time a clinical diagnosis, because in simple radiological studies, for example, an ultrasound abdomen won't relieve in anything else. But if the ultrasound is normal, that doesn't mean the patient is not going through acute appendicitis. We use a really good and a very effective score named as Alvarado score, or the mnemonic is MANTRALS, with M, migratory pain, A for anorexia, N for nausea and vomiting, T for temperature, E for elevated leukocytosis or the increased white count, right-sided neutrophil shift. These are the signs and symptoms when you apply on Alvarado score or a MANTRALS. The mnemonic is MANTRALS. You tend to have a score which you predict or you predict or take it as if this patient is going through acute appendicitis or not. 5 to 6 is likely acute appendicitis or unlikely acute appendicitis. With 7 to 8, there are higher chances of acute appendicitis. With 9, score more than 9 to 10, it is likely an acute appendicitis. So what to do? How would you assess how would you go for a radiological study or confirmatory test in acute appendicitis? Is CT scan abdomen with contrast. You will see a fatty streak on CT scan. That shows an acute appendicitis. As you know, appendicitis is when the lumen is blocked with fecalith or an infection. There is increased distension of the appendix. So as an emergency physician, what you have to do, pain relief, antibiotics if required, and urgent surgical referral. So as you can see in this diagram on the left side, this is an inflamed appendix. Ultrasound at times is normal. And we do in patients, for example, in patients who are pregnant, because radiations in pregnancy can have a harmful effect on the fetus. So we start off with ultrasound. If ultrasound upper abdomen or a pelvis is normal, that doesn't mean the patient is not having acute appendicitis. Although CT scan with contrast is the diagnostic or a gold standard to use in acute appendicitis. So CT scan, as it showed in this diagram, is diagnostic in for patients in acute appendicitis. So acute gastroenteritis, it is a very common presentation, a very common disease patients come across, and you get to tend to receive in emergency department. The patient present with vomiting and diarrhea. Multiple episodes started off suddenly. There might be diffuse or mild pain, generalized abdominal pain. There might be a fever, a low-grade fever, which indicates a viral gastroenteritis. There would be no blood in the stool, no foul-smelling stool. It might be a watery diarrhea. A traveler's diarrhea or foodborne diarrhea or foodborne acute gastroenteritis is very common. You come across these patients readily in an emergency department. So acute gastroenteritis, nausea and vomiting before pain. At times, gastroenteritis present with abdominal pain, but if with careful history, they will tell you there was a nausea, feeling of a nausea and multiple episodes of vomiting. But remember one thing: acute gastroenteritis or diseases which cause increased fluid loss, while they present to you in emergency department, you have to realize this patient should not go into a hypovolemic shock. You have to take care of all the things that are causing the fluid loss, because hypovolemic shock is acute emergency. Acute gastroenteritis is very, very easy to manage, but hypovolemic shock is at times could be difficult for you to manage. So pain poorly localized, diarrhea and fever. Fever might be present, which shows a bacterial agent for gastroenteritis, or mild fever, which might be with viral gastroenteritis. Watery or no stool is noted, and there is no blood in stool. Remember one thing: while moving on and while dealing with acute gastroenteritis, patients with gastroenteritis, you have to look for vital signs, which we explained before in the part 1 of acute abdomen, how to approach in a patient with vomiting. So with acute gastroenteritis, you have to see if the patient is stable enough to be sent home. You can go for multiple lab investigations to rule out any electrolyte imbalances or any renal function deterioration. You can go for a stool RE or over cultures to rule out what might be the cause of acute gastroenteritis. But most of the times, it is symptomatic treatment, and the patient will be sent home with oral rehydration supplement. So moving on to acute pancreatitis. Acute pancreatitis is a very, very important and is high yield subject to be addressed while you receive a patient in emergency department. Acute pancreatitis is when autoenzymes infect or digest or injure the pancreatic cells, leading to signs and symptoms of acute pancreatitis. How would a patient present? The patient will present with excruciating epigastric pain radiating to back, and it is associated with nausea and vomiting. So what might be the cause of acute pancreatitis? There are lists of them. What's a very good mnemonic to remember? That is gut smashed. G for gallstones, E for ethanol, T for trauma, S for steroids, M for mumps, A for autoimmune, S for scorpion, H for hyperlipidemia, D for drugs, which includes valproate, diuretics, azathioprine. They can cause acute pancreatitis. Before moving on, there are 2 different scores that you need to remember and you need to understand. They're very, very important in evaluating the patient with acute pancreatitis, because the complications of acute pancreatitis are very, very dangerous. So there are 2 scores: acute physiological and chronic health evaluation, that Apache score 2 and Glasgow score. We'll not go into the details of what these scores are, but at this point you need to remember what are the 2 types of scores that are required, that you need to know to evaluate the severity of acute pancreatitis. But on the other hand, the few determinants that you must know can help you identify this patient is in fatal acute pancreatitis. For example, obesity, Apache score more than 8, Glasgow score more than 3, CRP of 150, organ failure. These are the signs and symptoms or a presentation that would help you to identify this patient is going into a fatal acute pancreatitis. What are the complications of acute pancreatitis? These are very, very important. The local complications include pancreatic abscess, necrosis of the pancreas, pseudocyst, biliary channel problems, ascites, portal hypertension, portal vein thrombosis. With systemic, it might include adult respiratory distress syndrome, sepsis, organ failure, hypocalcemia, hyperglycemia. These are very, very fatal at times. So you need to identify acute pancreatitis as quick as you can. So what to do, how to approach in a patient with acute pancreatitis? First, when you think of acute pancreatitis, what lab investigations do you need? Complete blood count, serum electrolytes, liver function test. At times it turns out to be normal. Then you have to look for lipase. Lipase is very sensitive and specific, although in many hospitals amylase is used. But amylase is not specific, not sensitive as well. But if amylase is 3 times the normal, think of acute pancreatitis. What radiological studies would you go? CT scan or CT scan dynamic studies of the pancreas. These are very, very important investigations that you have to know. How would you treat a patient? Fluid resuscitation, oxygen supply. Again, you have to go back to A, B, and C. Fluid resuscitation, oxygen supply, NPO, nil per oral. What happens is what the rationale of putting a patient NPO is when you eat, there is increased production of the enzymes from the pancreas, which increase or exacerbate the outer digestion of the pancreas. Broad spectrum antibiotics should be used, or the patient might need an urgent ERCP. So mid-epigastric pain or lower upper quadrant pain radiates to back, chest over lower abdomen. Supine position exacerbates the pain. Serum lipase is a lab test, but for radiological studies, you need to move on for CT scan. This patient should be referred to gastroenterologist or a surgical specialty for further management. So moving on to aspirin intoxication, and simple words, salicylate poisoning. It is a very, very important toxicology emergency that present with nausea. There are multiple things. They are divided into mild, moderate, and severe, according to the drug intake. For mild, it is 125 milligram per kg. For moderate, it is more than 250, and for severe, it is more than 500. Salicylate aspirin is a salicylic derivative. It is metabolized in liver and excreted in urine. How would a patient present to you with aspirin toxicity? Altered mental status, headache, tinnitus, abdominal pain, tachypnea, and abdominal tenderness. But as I mentioned before, it is divided into 2 parts, mild to moderate and moderate to severe. They have different presentation. With moderate to severe, with aspirin or salicylate poisoning up to more than 500 milligram per kg, there might be altered mental status, metabolic acidosis, hyperpyrexia, altered mental status, and organ damage or pulmonary edema as well. So these are the signs and symptoms of aspirin toxicity. What happens is the aspirin toxicity present with two types of acidosis, metabolic acidosis and the respiratory acidosis as well. Metabolic acidosis is far more the common when aspirin toxicity. How would you manage a patient? What lab investigations do you need? Salicylate levels. If it's mild, that should be taken after 4 hours. But if it's severe and you're suspecting a severe, you have to take it after 1 hour of the intake. You will keep on repeating the test with 3 hours duration, with 3 hours interval for swear, until and unless you reach the peak, or you tend to have a decrease in salicylate levels. Why? Because salicylate tends to be absorbed again and again, and it will take time to reach the peak of absorption and tend to go back to the normal as well. It will take time. So you have to repeat the aspirin or salicylate levels after every 3 hours interval. What are the signs and symptoms of swear poisoning or fatal outcome of aspirin toxicity? As I mentioned before, end organ damage, pulmonary edema, hyperpyrexia, altered mental status. These are all signs of mortality in patients with aspirin toxicity. How to treat them? There are 3 main modalities. Activated charcoal, you give within 1 hour. At sometimes you can proceed for gastric lavage if within 1 hour. You have to take care of the metabolic acidosis with alkalinization of the urine. How do you do that? You have to maintain the pH of the urine to more than 7.5 to 8. It increases the excretion of the salicylates outside from the body. How do you do that? You give soda bicarbonate or sodium bicarbonate. You replace the acid with bicarbonate. And next is rehydration and rehydration. So LFTs, lab investigations that you require, apart from salicylate levels, complete blood count, and coagulation profile. Moving on to biliary tract diseases. It is a very common disease you come across in patients, especially in females. These symptoms, the signs and symptoms, are common presentation in emergency department. So biliary tract disease, most commonly caused by gallstones. 95% of the patient present with right hypochondrial pain. That is related to gallstones. Either they might be having a history or it's their first time. But what is the common presentation of biliary tract disease? Right hypochondrial pain that tends to radiate to right scapular region. They might have a history of similar pain in the past, associated with nausea and vomiting. What happens is there is collection of gallstones inside the gallbladder, and where that gallstone move into the common bile duct, that produce symptoms. With symptoms, the sign and symptoms of acute cholecystitis or choledocholithiasis are produced. So, what to see in this patient? The patient present with right hypochondrial pain associated with nausea and vomiting. And on examination, you can tend to have a positive Murphy sign. What is a Murphy sign? Murphy sign is when he asks the patient to inspirate, there is a hole in inspiration because of the pain and tenderness he elicit in the right hypochondrium. So, biliary tract disease, crampy right epicardium, radiates to right subscapular region. Prior history of pain is common as well. They might be having a normal temperature, but if it's acute cholecystitis or acute cholangitis, that might present with fever. Right epicardial tenderness and Murphy signs are positive in acute choledocholithiasis. Ultrasound is the diagnostic of choice. Ultrasound demonstrates stones, location, the size of the common bile duct, and much more information about the gallbladder. They might be presented with a sludge. They might tell you a sludge in gallbladder, a stone in gallbladder, or a common bile duct, that smearing of certain amount. Ultrasound demonstrates the anatomy of the biliary tract, stones or duct dilation. As I mentioned, common bile duct, which is dilated because of stone. At times, the pain is intermittent. For example, a patient tells you he had this similar pain, but no intervention was done, and the pain went away. So that means that there was a stone which has passed now. So there is another stone that is coming from a gallbladder, distended gallbladder, that is causing the symptoms and blocking the common bile duct. So hepatobiliary demonstrates gallbladder functions. CT may demonstrate a pathology. So we have to treat, you have to treat acute cholecystitis with analgesics, broad spectrum antibiotics. You have to treat the infection first, and then you have to plan for cholecystectomy. What are the lab investigations that you might require in patients with biliary tract diseases, for example, in acute cholelithiasis and acute cholecystitis? Complete blood count, coagulation profile, liver function test, which turns out to be normal most of the time. Serum amylase and lipase level if you're suspecting pancreatitis. And ultrasound is again the diagnostic of choice. Boerhaave syndrome. A patient presents to you with acute, severe, unrelenting, and diffuse pain in the chest, neck, and abdomen, with radiation to the back and shoulders. Pain is exacerbated by swallowing, tachycardia, and tachypnea. Usually, these patients are unstable. Abdominal rigidity and with hypotension, cervical subcutaneous emphysema or Hammond's crunch you see on auscultation. So what are the investigations you could do? Chest X-ray with water-soluble contrast, esophagography, endoscopy and CT scan of the chest, thoracentesis. Thoracentesis is not widely used now, but Boerhaave present with a retching kind of pain and nausea and vomiting. So these patients are usually unstable. You have to treat them. You have to treat the tachycardia and tachypnea. And these are the lab investigations you could offer to the patient to get to the diagnosis. As I mentioned before, cholecystitis, presenting with the right upper quadrant pain, signs of fever, tachycardia, patient might be having dehydration, increased respiratory rate. Cholecystitis, how would you treat? You would treat with antibiotics, analgesics, and rehydration. Moving on to diabetic ketoacidosis. It's a diabetic emergency. We have discussed it in detail under the section of diabetic emergencies. But for now, I will talk about some of the common or summarize this case for you. Diabetic ketoacidosis commonly present with nausea and vomiting. They are mainly in patients with type 1 diabetes and patients who are younger. Type 1 diabetes is most common in younger patients. There might be a history of a preceding infection or an infection that was preceded by diabetic ketoacidosis. How would a patient present to you? Severe abdominal pain, nausea and vomiting. There might be a sweet, fruity breath you could appreciate is also a sign and symptom of diabetic ketoacidosis. There might be cosmal respiration. There might be decrease in conscious level, altered status. So you check on the blood sugars. They're more than 600 or more than 250. You go for an ABGs, you find an acidosis, pH of less than 3.5, with bicarbonate less than 15. So these three criteria, and one more, that is blood ketones. If these three are positive, think of diabetic ketoacidosis. But how to treat diabetic ketoacidosis is very, very important. The treatment of choice is fluid, and fluid. You have a certain scale that a certain amount of fluid that you have to give to the patient. First thing you do, you decrease the blood sugars with IV insulin and insulin infusion, that is 6 units per hour, followed by 1 liter of fluid in first 30 minutes, moving on to second liter of fluids in next 1 hour, and subsequently increasing the fluid. We'll move on to antibiotics. Keep on repeating patients' VBGs, venous blood gases, to know the bicarb levels, to know the level of the pH, and you have to measure the output as well. These patients need ICU admission and ICU critical care unit. So these are the common things you might come across in patients with diabetic ketoacidosis. Vomiting is a common symptom in patients with diabetic ketoacidosis. So serum glucose test, ABGs, venous blood gases if ABGs are unsuccessful. So again, the treatment of choice: decrease the blood sugar with insulin, IV insulin, monitor the insulin after a certain amount of time, check on the potassium, replace potassium if required, fluids, give fluids, and antibiotics. So moving on to another very important topic that present with vomiting, that is GI bleed. And this, the vomiting is called hematemesis because there is blood in the vomitus. Either that blood would be a dark maroon color or a fresh blood. But as an emergency physician, you have to realize that GI bleed is an emergency, is a critical emergency. You have to be on your toes to treat GI bleed. How to approach in a patient with GI bleed? We have covered a lot of things under the section of gastrointestinal bleed, what to do and how to approach in a patient. But in patients with hematemesis, this is a red flag sign. First, you have to monitor the blood pressure. If the patient is tachycardic, give this patient fluids. If this patient is losing blood, replace blood with blood. If you, while taking the history of the patient or asking the caretakers or the family next to the patient, if there is increasing episode of GI bleed or hematemesis, think of a heavy blood loss. So with just hematemesis, if you know how to manage a patient, you could save a patient's life. So if the patient is bleeding maroon or the color of the blood is very dark, think of a chronic bleed or a bleeding is from past couple of few hours that has been clotted now. So there are multiple remedies to be done in patients. There might be, you can put a salt stake in bulk tube, you can go for an endoscopy, you can go for CT angiography, but that's discussed under the topic of GI bleed. But for now, with vomiting, you have to approach in a patient with, you have to maintain an airway, adequate breathing, and yes, that time comes for circulation. Replace blood with blood, you give fluids, and maintain the mean arterial pressure. So what lab investigations to be done in patients with GI bleed? Coagulation test, complete blood count, and electrolyte test. So these are very, very important and the baseline investigations that you need to have in treating the patient with GI bleed. Moving on to mesenteric ischemia. It's a vascular emergency. The patient presents to you with out-of-the-counter pain in abdomen. You might come across with the digital rectal examination heme-occlusive blood. So mesenteric ischemia is a vascular emergency and needs urgent surgical intervention. So they might present with vomiting, swear excruciating out of the manner pain. There are no certain similar episodes in the past. History of atrial fibrillation, or history of hyperlipidemia, or history of previous angiography that shows atherosclerotic patches. These are the previous history or past medical histories that is important in knowing the patients or treating the patient with mesenteric ischemia. So high leukocytosis, metabolic acidosis is present, increased amylase level, and increased creatine phosphokinase. And at times there is increase in lactate level as well. You have to treat mesenteric ischemia because without treating mesenteric ischemia, you could lose the entire intestinal gut. Intussusception is telescoping of the GI tract. The patient presents with vomiting. You can move on. You can evaluate with a simple X-ray, erect abdomen, or you might need a CT scan. Now comes a very important topic: myocardial infarction. Vomiting is a common symptom of a myocardial infarction. With MI or cardiovascular accidents, they have a similar complaints like of with pain in epigastrium or gastritis or features of gastritis. But you have to be sure to rule out first the cardiovascular accident. How would a patient present to you with myocardial infarction? Sudden chest pain, or there might be no chest pain in patients with diabetes. Patients with risk factors of hypertension and diabetes, or family history. Patient might present to you with chest pain associated with nausea and profuse vomiting. The pain is constant, radiating to left arm or neck. There is profuse sweating. Think of a myocardial infarction. Get an ECG within no time. Won't take much of your time, but could give you a lot of information. These are the signs of acute cardiac event. So first get an ECG, and this is a somewhat normal ECG, if you can see, but in 70% of the cases presenting with chest pain, they tend to have an abnormal or ST elevation MI or non-ST elevation MI. So you have to treat them accordingly because that's life-saving maneuvers. Again, simple vomiting with chest pain can lead you to a diagnosis of myocardial infarction. Moving on to ovarian torsion. Ovarian torsion is a gynecological emergency. In this, females present with unilateral sudden onset of excruciating pain associated with nausea and vomiting. This pain is lower abdominal or pelvic in position. The pain changes with position and it is intermittent in nature. As you can see here, acute severe unilateral pain in lower abdomen and pelvis related to change in position and intermittent in nature. You might need a complete blood count and a pregnancy test. Why is pregnancy test important? Because at times patients with ectopic pregnancy present with lower abdominal or unilateral pain. So pregnancy test is required in patients if you suspect an ectopic pregnancy. Beta HCG levels and pregnancy test is required. Moving on to pyloric stenosis is commonly in infants, especially of more than 1 week and less than 3 weeks. They present with non-projectile or non-bilious projectile vomitus. The infants are dehydrated. They ask for or they cry for food again and again. These are hunger babies. They would not gain weight because of vomiting again and again because of pyloric stenosis. You tend to see a peristaltic wave and abdominal examination. You might see an X-ray double bubble sign. So this is an important disease that is most commonly affected in young infants. So pyloric stenosis, abdominal ultrasound is required, complete blood count, glucose administration because of dehydration, and IV hydration is required. Glucose administration because of hypoglycemia, persistent hypoglycemia. Subarachnoid hemorrhage. It is a very, very common and very, very important neurological emergency you come across in an emergency department. This patient would present to you with severe headache or vomiting. This patient might present to you with many symptoms, for example, vertigo, dizziness, inability to walk, inability to stand, falling off a certain side, history of migraine, history of hypertension. These are very important predisposing features of causative agents of subarachnoid hemorrhage. So patient might present with history of fall, history of trauma, head injury. But the common symptom is vomiting, nausea and vomiting. So let me give you a scenario. A patient presents to you with worst headache of life, known case of hypertension, comes to you with worst headache of life associated with nausea and vomiting. You do a CT scan and you find a subarachnoid hemorrhage. It is at times hard to differentiate, but most of the time it is hard to differentiate. The vomiting is due to subarachnoid hemorrhage, intracranial bleed, or ischemic stroke. You have to go for a radiological imaging to rule out any of these. So glucose test is required because the patient presents with drowsiness, altered mental status, nausea and vomiting. First, a glucose check is required. EKG is required, brain CT, lumbar puncture if the CT is normal. Moving on to other differential diagnosis, testicular torsion. It's a urological emergency. How would a patient present? Patient present to you with unilateral scrotal pain, with nausea and vomiting. There is an horizontal lie of the testicle, that is French sign, and there is loss of cremostatic reflex. That is characteristic of testicular torsion. But again, as an emergency physician, you have to take urologist on board within 6 hours, because this patient needs untwisting of detorsion of the affected testicle to protect the testes from infertility and for necrosis. You have 6 hours window period. We'll talk more in detail about the testicular torsion under the section of genitourinary emergencies. So let's go to the description. History of an athletic event, sternus physical activity or trauma, may awaken from sleep with unilateral testicular pain. Color flow duplex is the best choice. It shows decreased blood flow to the affected testes. Doppler ultrasound is required. Radionuclide is required as well. At times could be useful in patients, but that tend to show a decreased uptake of the dye in affected scrotum or testes. Urinary colic, a common presentation, a common disease you come across in patients with an emergency department. The patient will present with ipsilateral flank pain and ipsilateral radiation of the pain to the groin. There might be fever, there might not be fever. The pain is constant, intermittent, and you might find a cervical or costal vertebral angle tenderness or renal angle tenderness. Renal punch might be positive. You go for a urine analysis, you see hematuria. You go for a helical CT, that is non-contrast, readily available, and can show you a radio-opaque stones as well. It is within no time. But ultrasound is also required in patients who are females, for example, patients with female or patients who are pregnant. Pregnant females require ultrasound to rule out any urinary colic stones. Acute onset of flank pain radiating to groin, patient breathing in pain, bloody urine, hematuria as I mentioned, hematuria in RBC cells and urine. Patient costal vertebral angle tenderness is positive, and this patient needs the diagnostic of choice is helical or spiral CT. Again, this patient present with ipsilateral flank pain, nausea and vomiting. Vomiting is a common sign in these patients as well. How do you treat them? You give them analgesics with that is ketorolac, NSAIDs, and paracetamol or IV paracetamol. You move on if the pain is not treated. You move on and top up with another opiates or other options that you have for analgesia. You have to measure this stone in a CT scan, and you have to give an appropriate management plan to the patient. See, why is CT scan more diagnostic in patients with urinary colic? Because with CT scan, you can notice an hydronephrosis, the location of the stone, the shape of the stone, and the size of the stone. Vertigo. Vertigo can at times be due to posterior cerebellar circulation infarct, or the patient might be going through a benign positional vertigo, or there might be an ear infection that is causing the middle or inner ear infection that is causing the vertigo. But the common symptom in all these kind of vertigo is vomiting. The patient presents with spinning of the head with vomiting. So how do you treat them? Symptomatic treatment, CT or MRI if you need if you're suspecting a posterior circulation infarct. You need an urgent neurological consultation for if the CT or MRI turns out to be a posterior circulation infarct. Moving on to volvulus, that is twisting of the intestine. It presents with bilious vomiting, with or without abdominal distension, streaks of blood in the stool, that is heme occult blood, and pale with grunting respiration. These are the common presentation symptoms you would see in a patient with volvulus. What to do in a patient? Patient needs an X-ray abdomen and a complete blood count. At times, and most of the time, this patient needs an emergency surgical laparotomy or exploration to relieve the pain, to relieve the signs and symptoms of volvulus. But again, what is the common presentation of volvulus? It's abdominal pain with nausea and vomiting. So, coming on to general treatment plan in patients with vomiting. I did talk about some of the specific diseases and specific treatment plans related to those diseases, but as a vomiting as a whole, you will talk about what are the general treatment plans we have for volume repletion. First thing, as an emergency physician, I've been repeating that again and again in my lectures, you have to go for an airway, breathing, and circulation. Address airway first. If it's not patent, address the airway, check on the airway, then move on to breathing. If breathing is not adequate, treat the breathing problem first, then move on to circulation. If the patient is in circulatory collapse, how would you know if the patient is in circulatory collapse? First, check this set of vitals. We'll talk about more in detail and how we did talk about this in detail and how to approach in a patient with vomiting. But to know if the patient is going through a circulatory collapse, what are the signs and symptoms? Tachycardia, hypotension, dehydration signs, that is a dry tongue, white-coated tongue. Signs and symptoms of dehydration includes altered mental status. If there is hypotension, as I mentioned before, these are the signs of circulatory collapse. You have to treat the patient these signs and symptoms first. So what to do? Venous excess, 2 large bore IV cannulas, fluid bolus of at least 20 ml per kg normal saline. This is very, very important. You have to maintain the mean arterial pressure for more than 65 in patients who are dehydrated. So you have to protect the patient from hypovolemic shock. If the patient is stable, there is no tachycardia, blood pressures are normal, patient is with normal GCS, go for oral rehydration or IV rehydration if the patient cannot tolerate orally. Antiemetics, these are also used in patients with vomiting. There are centers, as we did talk about some of the centers of the vomiting in lecture number 1 of acute vomiting. There have some receptors, for example, receptors for dopamine, receptors for 5-HT3 prokinetic agents. So antiemetics are dopamine antagonists, which includes prochlorperazine, 5-HT3 antagonist, ondansetron. This is widely used. The dose is 4 milligram IV or 8 milligram IV, or prokinetic agents, for example, motilium or metoclopramide. These are widely used in patients with persistent vomiting or new onset vomiting. So moving on to special patients. For example, vomiting in pediatric population. Vomiting is a very, very common symptom in pediatric population, like mainly in newborns. But if the vomitus is projectile, think of pyloric stenosis. If the vomitus is bilious in infants, think of volvulus or intussusception. But you have to maintain the hydration status. In newborns and in infants and children, there are a few categories that might present with vomiting. For example, metabolic, ketoacidosis, mechanical. There might be signs and symptoms of volvulus or intussusception, pyloric stenosis. Acute viral or bacterial gastroenteritis could present with vomiting. There are certain things you need to address in a pediatric population. So the mainstay of the treatment in a pediatric population is to maintain the hydration status. How would you maintain? Even if a patient is vomiting, if a kid is a pediatric population infant is vomiting, you have to rehydrate even with oral rehydration or with IV rehydration. With moderate to severe pediatric population, vomiting or dehydration is addressed with around 20 ml per kg fluid bolus. So you have to maintain the hydration status in pediatric population. Moving on to elderly or advanced age members, they are prone to get vomiting in very serious diseases. For example, in cardiac diseases, for example, in patients with increased ICP or is posterior cerebral strokes or any tumor inside the brain. These can cause the signs and symptoms of vomiting or increased ICP. There might be the patients might be having bowel obstruction, that is adhesions. With advanced age or post-operative, there are signs and symptoms of adhesions, which tend to have a constipation. A patient present with bilious vomiting or a fecalith vomitus. So elderly patients are prone to these diseases, and when you evaluate a patient or elderly patient with vomiting, you have to think of a very serious diseases that you might not think in a younger population. As I mentioned before, you have to rule out the cardiac diseases, any intracranial pathology, any gastrointestinal pathology. So these are the common complications, the common problems you come across in an elderly population. Moving on to pregnant females. Pregnant females tend to have a vomitus in first trimester. That is hyperemesis gravitarum. They tend to feel nauseated. So the mainstay of treatment in a pregnant population is hydration, hydration, and hydration. Why? Because if there is not enough hydration, there is increased risk of miscarriages. So palliative care, end of the life care. At times, there is abrupt onset of excruciating onset of vomiting in palliative in patients at end of the life. The patients who are tumor with Mets, the patients who are bedbound, who are poor prognostic diseases, they're named under the palliative care. They are treated under palliative care, so their treatment should be adequate to relieve the vomiting and to provide as much comfort as we can as an emergency physician. Moving on to disposition of the patients with vomiting. All the life-threatening problems that are associated, that present with vomiting, these patients need an in-hospital admission. These patients should be admitted, for example, acute pancreatitis, acute appendicitis, volvulus intussusception, bowel obstruction, elderly population with certain risk factors, myocardial infarction presenting with nausea and vomiting. These all need a hospital admission. And patients with vomitus and excessive fluid loss needs admission as well. And the patient who cannot tolerate orally, even after giving the antiemetics, needs admission as well. But the patients who are stable, who could be sent home, or who can tolerate orally, that's what we term as per oral challenge. If you receive a patient with vomiting, all the vital signs are normal, the patient is stable enough, give that patient an oral trial challenge. If the patient can tolerate it, you can send that patient home easily. So in this lecture, we talked about some of the very common and life-threatening diseases that present with vomiting. We talked about more of the details about acute appendicitis, some of the toxicity, which includes salicylate poisoning, acetaminophen poisoning. We talked about in detail about acute pancreatitis as well. We talked about myocardial infarction, cholecystitis, and some of the diseases, which includes the female and male genital system. We talked about the renal colic. We talked about the vertigo and dizziness. We talked about the posterior cerebral circulation and fog. We then talk about some of the special population, which includes pediatric population, elderly population, and pregnant females. We then talked about the patients with end-of-the-life care, that is palliative care. We then talked about the patient with a disposition of the patient, which includes if the patient is having a life-threatening or abnormal or life-threatening problem due to vomiting, or any life-threatening diseases that is causing vomiting should be taken care in a hospital. And a patient with who are stable enough, who can tolerate orally, who have no abnormal vital signs, could be sent home with follow-up to general physician. That's all for now. Thank you for watching.